Thank you, Rama, for a very kind introduction, and I'll look forward to chatting with you later. And thanks for inviting me, Noreen and Jim, and it's been a while since I've been to OPR. I forget exactly when, maybe a decade ago. But anyway, it's nice to return to see you all, at least virtually, and to have a few minutes to share what I've been up to with you all. So thanks again for coming out today. So let me share my screen and do this slideshow thing. Okay, how's that? Is that great? Okay, thanks. So as I was reflecting about what to talk about today, I'm working a lot of different things right now, most of it not research, and PA meetings and staff meetings for Ad Health and so forth. By the way, PA starts May the 5th. If you haven't registered yet, please do. We're hoping to have a great meeting. So what do I want to talk about? I thought about Ad Health data and some of the descriptive work that I like to do that I think I do best. And that's what I'll share with you today is a combination of these things. It's some things I'm working about and thinking about and working on, and you'll hopefully find halfway interesting and maybe stimulating for at least some postdocs and students to go further with. So until COVID-19, when I think about population health research in the United States, the recent research has been dominated by the opioid epidemic, and justifiably so. There were early reports of celebrity deaths, and then the epidemic really took hold, and hundreds of thousands of Americans died as a result. And then in 2015, your colleagues Ann Case and Angus Deaton published their now famous paper on increasing midlife mortality in the United States, showing this overall rise in U.S. midlife mortality due to cause of death associated with drugs, alcohol, and suicide. And then NCHS reports began to document slightly decreasing life expectancy in the United States, life expectancy at birth, which is really troubling for population health scholars like myself. We rarely see this, and we hadn't seen 3 years of decline in life expectancy for about a century. So such reports also largely implicated the opioid epidemic and all the ensuing deaths. And at the same time, life expectancy continued to increase slowly for other groups, including Blacks, and leading to the smallest Black-white disparity in life expectancy at birth that I've ever seen. And I think any of us ever have at about 3.5 years. So the question being, were we witnessing a fundamental change in health and mortality inequities? Were Black-white disparities going to disappear? Where they were becoming smaller, and kind of even larger questions associated with this is, were we seeing a change in kind of the racial hierarchy, if you will, in American society, as reflected in these kind of shifts in disparities. So there was a lot of scientific and policy concern about low-educated whites, and again, a lot of people dying. This is justified. Case and Deaton's great book that came out last year laid out the ideas that Black low-educated economic decline hit first in the 1960s and 70s in places like I know Jim and I are from in and around Detroit, and this happened with whites later as manufacturing sector fell apart, and both of these resulted in disparity-related mortality increases. I just was fortunate to be part of a National Academy's consensus study that came out just a few weeks ago on working age mortality. And we showed in that report that disparities in mortality by education have widened substantially among working age whites. And figuring out that story among low educated whites was a major part of the effort. As the consensus study went on, I found myself being more and more the one who was saying, well, wait, Blacks still have higher mortality than whites and so forth. And we wrote a lot about racial disparities as well. But a big part of that effort was on kind of what's going on with low educated whites. And then a recent Brookings report, and I'll just give you these 3 examples, America's Crisis of Despair, in the overview of that report summarized that these deaths are concentrated among less than college-educated middle-aged whites, those out of the labor force disproportionately represented. Low-income minorities are significantly more optimistic than whites and much less likely to die of these deaths, and highlighting that there needs to be policy attention to these increasing death rates among low-educated whites. And there has been policy attention. At the national level, this is one of the few things that our lawmakers actually agreed on in this Support for Patients and Communities Act that you see Trump signing in 2018, that had an array of support for reducing the opioid epidemic, enhanced screening for fentanyl, funding increases for treatment, funding for states to buy back unused pills, and so forth. So there's been substantial amount of resources put into the opioid epidemic and to fighting that, and again, in many ways justified by this too many people dying at far too early. But indeed, even with all of this attention and these shifts, COVID-19 hits and has exposed the highest health and mortality risk for Black and Hispanic and Indigenous and some data Asian adults relative to whites. And if we focus specifically on Blacks and whites, this life expectancy gap is that Noreen and her colleagues have shown is expected to jump back up to around 6 years once 2020 data are finalized. So the progress, if you will, of decreasing disparities will seemingly kind of go away soon. And then also very recently, there's recent evidence indicates that equivalently high COVID-19 mortality among low-educated Blacks and whites, so people with low education, really high rates of COVID mortality. But if you look at high levels of education, modestly higher Black than white COVID mortality among those with high rates of education. So low education, not good for anybody, but even among those with high education, rates of COVID mortality among Blacks modestly higher than those of whites. So some debate about exactly what's going on, but in both of these cases, race disparity is going to increase and education disparity is very wide with COVID. So these population health trends and debates kind of raise questions that I'm going to talk with you about today and bring some evidence to bear. The questions revolve around this kind of issues of race, racism, education, and health. And the questions being, how does the health of Blacks and whites compare across a range of health outcomes, not just COVID. In fact, I won't touch on COVID, so I don't have to add health data on COVID, but across a range of health outcomes when both race and education are taken into account. Are low-educated whites now the most disadvantaged group with regard to health and mortality? We've seen and heard a little bit about that in the media. How does the health and mortality of highly educated Black and white adults compare? I'm going to focus on young adults between the ages of roughly 25 and 50 or so, give or take. I'll use several different data sets, give or take a little bit, but largely focusing on this group of adults who are going to be middle-aged relatively soon. And then second, I'm going to focus on Blacks and whites only here. This is not to the exclusion of other groups in terms of my thinking and the broader work I've done over the course of my career and continue to do. But in terms of narrowing down the questions for this particular exercise, I'm going to focus here on US-born Blacks and US-born whites in order to best address these questions. Okay, in terms of thinking, I've been working with something like this conceptualization of race, ethnicity, and population health for a long time now. This particular diagram is one I published with Aaron Hamilton in a recent book on broad-based kind of textbook on population health in the United States, and of outlining our kind of broadly how we think about race and health and how disparities come to be produced through this kind of gray arrow, if you will, of racism. It also borrows largely on the ideas by David Williams and by Joe Phelan and Bruce Link, and in thinking about racism as a fundamental cause of health and mortality. That the reason why we see race disparities, and particularly Black-white disparities in health and mortality, has to do with how racism structures access to social resources across groups, and that those resources influence a broad range of mechanisms that go on to influence a broad range of health outcomes. So very much kind of a fundamental cause kinds of thinking about race, racism, and health and mortality. So that's a very broad way to think about this. So I'm going to answer these questions and provide some evidence, not definitively. I'm going to be humble about what I bring to bear here. I'm going to bring a little bit of descriptive data to bear, and hopefully get some people interested in doing a better job than I do in trying to address these questions. But I'm going to look at again, this age group of roughly 25 to 50 or so. Think about Black-white disparities. What do they look like in terms when they're also stratified by educational level? As the debates I tried to show you kind of highlighted, and what might be responsible for some of the disparities that we see. So first, I'm going to start with some mortality data that comes from the National Health Interview Survey longitudinal mortality follow-up. These are self-reported, and a big strength here is people largely report their own race and their own educational level. So self-reported cross-sectional data from NHIS, statistically linked to death records for over 10 years. And it's hundreds of thousands of adults in the age range of 30 to 49, so educational attainment is largely complete, and thousands of deaths. And again, I focus on US-born Blacks and whites, in part because I know how different the immigrant groups are when we think about Blacks and whites, and how different the mortality and health outcomes are for Asian Americans, for Hispanics, for American Indians, and so forth. So I'm intentionally being simplistic here. I'm also going to show the data for simply low-educated Blacks, high-educated Blacks, low-educated whites, and high-educated whites throughout all the different data sets that I use here. So these are the four groups I'll focus on. Yes, it's not everybody. I'm leaving out, people with middle levels of education, but in order to best illustrate, I think the key points, I focus on these four groups. Okay, first, looking at these estimated mortality rates using the NHIS data, I'm going to show you here four cause-specific rates, and then on the next slide, the fourth cause, and then all-cause mortality on the next slide. And highly educated people, college degrees or higher, are in the green. Low-educated people, high school degree or lower, are in the blue. And here I got accidents, which includes the drug poisoning deaths, as well as car accidents and other kinds of accidents, cardiometabolic causes of mortality and cancer. And then I'll show you other causes and all cause on the next slide. But I would like to draw your attention to four key points here. First, when focusing on accidents, rates for low-educated whites are by far the highest. Okay, as you might expect, given the drug poisoning deaths and suicides are also included in this accident. I should have clarified that. So see the blue bar for whites. Highly educated whites also have a higher rate than highly educated Blacks. So you see kind of higher white than Black mortality for this particular cause. And this is a lot of what's been written about and what I described earlier, the work on the opioid epidemic and so forth. Second, when focusing on the other cause categories, cardiometabolic, cancer, and other causes on the next slide, rates for whites are the lowest within educational categories. Again, so if you compare like cardiometabolic, highly educated whites compared to highly educated Blacks, the rate for Blacks is 4 to 5 times higher than that for whites. And for cancer, the disparity is not as huge, but also within levels of education, you see these disparities that favor whites and don't favor Blacks. And third, as expected for all groups and for all causes, rates are highest among the low-educated and lowest among the high-educated. This is no surprise, of course. Educational disparities are seen in all kinds of U.S. population health data. But fourth, I won't focus on the other causes, but I'll focus here on all-cause mortality. And if we look at all-cause mortality as an indicator of the overall population health of this age group of people, you'll see that there are very wide racial disparities in mortality, even within categories of educational attainment. Black rates are 40 to 90% higher than white rates within educational attainment categories. So the idea that that low-educated whites have the worst population health in the United States, even among this relatively young, this group of young adults, is just not true when looking at this age group of folks, and an indicator like a broad indicator like all-cause mortality. Very much true for accidents, not at all true for all causes. Okay, I'm also going to take a minute to think about infant mortality. A lot of births, of course, are to women who are in this age range as well. Here I look at women ages 25 and above. Again, most educational attainment is complete, except for people like us, by this age. Using here national level birth certificate data linked to infant death records for these 4 years. And so there's over 7 million births in this file to women aged 25 and over 400,000 deaths. So a lot of power here. And again, the same focus on U.S. born non-Hispanic Black and non-Hispanic white women by educational attainment. This comes from a paper I recently published with Sam Fishman and colleagues in biodemography. Okay, and I'll just show you one simple graph from that paper. Here, the results, again, the same groups, low education, high school degree or less, high education, college degree or higher. The results not only show far lower infant mortality for whites relative to blacks at both levels of education, but even a lower rate for low educated whites relative to highly educated blacks. Okay, we've seen this in several papers throughout the years. This is the most updated data showing this. The idea here that there is both either equity between groups when education is when we look within categories of education is not true at all, or that low educated whites have the worst population health in the United States is simply not borne out at all with these data. The paper itself actually goes on to look at some of the reasons why, and the big reason, when you adjust for levels of gestational length or prematurity across groups, it completely eliminates these disparities. And the idea being that Black women of all educational levels have higher rates of prematurity than white women of all educational levels. And the higher levels of prematurity largely due to the stress process that women encounter when giving birth in the United States, how does stress get embodied within women, and once you equate levels of prematurity, these disparities go away. Okay, I'm next going to turn to look at some health outcomes. Again, roughly the same age range of people, young adults in the United States, and I'm going to turn toward to Ad Health data, which I know best now to think about this. And here I'm going to use data from Wave 5 of Ad Health, which was collected between 2016 and 2018. And the individuals in Ad Health are at this point in their cohort history, average age of 38, ranging from 34 to 43. I'm going to draw on the survey data of over 12,000 individuals, and among whom we were able to collect biomarker data from about 5,000 of them. So I'll show you some health outcomes from both the survey data, excuse me, and the biomarker data. For those of you not familiar with Ad Health, and I'll try to encourage people to acquire and use Ad Health data at the end of the talk here. The data are representative of individuals who are enrolled in U.S. middle and high schools in the mid-1990s. So this is a representative sample of people who have been followed ever since, that was drawn from a list of middle schools and high schools at the time, private, public, so forth. So there hasn't been people added to Ad Health since then. So, Ad Health data do not have, for example, immigrants who come in their late teens or 20s in Ad Health. This is the cohort was drawn from these middle school and high schools in the mid-1990s and followed ever since. So I'm going to focus here on self-reported race from Wave 5. We've asked race in different ways over time. This is the self-reported race data from Wave 5, educational attainment at Wave 5, and a range of health outcomes. And here I'm going to show you two basic models. I'm going to show you 4 health outcomes. I've run these same equations on 10 health outcomes, and I'll summarize later for those 10. But I'm going to show you here, just not to overwhelm folks, four different outcomes. The first model I'm going to show you is just the basic race education disparities, just like you saw for mortality a few minutes ago, controlled for age and sex. So again, what are the baseline disparities in question here? And then second, run a range of models that have included, okay, why are there these disparities by race and education? And so I'm including in these a bunch of individual level socioeconomic measures across the life course, from adolescence, parents' education, parents' income, whether the family was getting free lunch back when the kids were in high school, SES measures when they became adults, their current incomes, whether or not they've been foreclosed on or evicted recently, their subjective social status, thinking about their socioeconomic status and so forth. And then wave 5 measures of stress and coping as well. So measures of stress that use the Cohen's measure of stress, asking about whether or not the individuals are having unable to losing control of life. Are they confident in handling personal problems? Are things not going your way? Are difficulties piling up? These kind of individual level measures of stress that we're tapping into here. And then measures of discrimination as well. Are you being treated with respect or less respect or courtesy, poor service? People don't think you're smart. People are afraid of you. People think you've been threatened or harassed by others. So there's measures of stress, both the Cohen's measure, discrimination measure, and measures of stress that tap into whether or not you've been unfairly stopped by police, whether both parents have died at this point in the life course, and so on. So simply put, there's a range of measures that tap into kind of life course measures of socioeconomic status and recent measures of stress, discrimination, and coping as well. Coping like access to religious attendance and marital status and so forth. Okay. So let's look at the first outcome I'm going to look at here is illicit drug use. And this is just measured dichotomously. Do people at roughly age 38 here report using illicit drugs like heroin or cocaine, or using drugs that haven't been prescribed to you, like overusing opioids? So it's a question that combines those kind of responses. And these in all of these data, I'm looking at just logistic regression coefficients here. So coefficients above 0 reflect higher odds of using, in this case, poorer health, or in this case, using illicit drugs. Coefficients below 0 are lower odds of whatever the outcome is. And the 4 groups, again, I'm looking at low educated Blacks in the navy blue, high educated Blacks in green, low educated whites in the orange, and then the reference group here, highly educated non-Hispanic whites, those with a college degree or higher. Okay, so the first, and I'm going to characterize the patterns that I see in these data in this range of outcomes as kind of, I see kind of 3 patterns emerging from this set of 10 outcomes I'm looking at. And this findings on drug use is the first pattern that I'm going to describe to you. And this is the idea that low educated whites do stand out as the most uniquely health disadvantaged group when compared, looking at these 4 groups. You see the orange bar there. In the simple model, just controlled for age and sex, you got these high levels of illicit drug use or overuse of drugs among low educated whites here. The other 3 groups don't differ from one another. Okay. In the second model, again, one-set control for these kind of social resources and stress markers. Low educated whites, that excess high levels of drug use disappears here. And the key covariates that helped to make that disparity disappear was adolescent poverty, having no or negative wealth, and experiencing divorce or high levels of stress as an adult. So again, the social resources and stressful living conditions completely erase that high levels of drug use. But interestingly as well, you see what happens with the patterns for blacks, both especially low educated blacks, when you control for those same variables compared to highly educated whites. Low SES really helps to makes an impact, as well as reports of discrimination, unfair police treatment, and prior incarceration. So that once you control for these SES measures and stressful living conditions, low educated blacks actually have lower rates of lower odds of drug use compared to highly educated whites. So the idea being here that if you equated these socioeconomic conditions as best as possible and the stressful living conditions, the rates of drug use would be lower among blacks, especially low educated blacks compared to whites. Okay. A second pattern that I see emerging in these outcomes that I look at is illustrated here by looking at self-reported health. And this is, it has its faults. Comparisons across groups are notoriously difficult to make with self-reported health, but less so when you compare blacks to whites. So this is kind of this overall kind of how healthy are you? And again, higher coefficients here is higher odds of reporting fair or poor health. So not good to have a tall, high bar here. Okay, so what is illustrated here is that both low-educated blacks in the blue and low-educated whites in the orange are highly health disadvantaged compared to highly educated whites. We know that. But highly educated blacks are also clearly disadvantaged compared with highly educated whites as well in the green. Okay, and this equates, this regression coefficient equates with something like a little over twice the odds of reporting fair and poor health compared to highly educated whites. So pretty sizable difference here. Okay, when we look at the second model here, again, controlling for these socioeconomic and stressful life conditions, the variables that really kind of came into play to help reduce or eliminate these disparities, including living in poverty as an adolescent, current low income, being exposed to foreclosure or eviction in recent years, having no or negative wealth and low subjective social status. So these socioeconomic disparities, even outside of educational level, help to reduce the coefficients for all groups compared with highly educated whites. But in addition, for blacks only, for both low educated blacks and highly educated blacks, unfair police treatment and both parents deceased were also important in helping to reduce these disparities. So it's this combination of socioeconomic disadvantage across the life course and also stressful conditions that were particularly important for blacks compared to whites. Okay, the third kind of pattern I'm going to show you is true for both these last two health outcomes I'll look at, and these are high CRP levels, which is a marker of poor immune functioning among these adult respondents. And the second one I'll look at is hypertension, and the patterns are pretty much the same when you look at both these. The idea being here is that low educated blacks in the blue stand out as exhibiting the most pronounced health disadvantages, whereas low educated whites and high educated blacks are roughly similar with one another in model one. So we saw that earlier with infant mortality as well. So here, there's no sense at all that low educated whites are the most health disadvantaged in American society in this age group. In fact, we see very clearly that there's low-educated blacks are really standing out here. Again, when we move across to the model that includes a lot of the covariates that I've been talking about, the ones that really stood out in reducing these coefficients for included low adolescent income, low status, and this is so. low income, low subjective status for both whites and blacks compared to highly educated whites. But then the reports of discrimination were also really important here for reducing the coefficient for, especially for highly educated blacks compared to highly educated whites. So when people are reporting higher levels of discrimination, that's also associated with their higher levels of CRP and helping to reduce that highly educated black to highly educated white disparity. So, and you see nearly the same thing for hypertension as well. Low educated blacks standing out with the highest risk, highly educated blacks and low educated whites similarly disadvantaged. And then the coefficients that were important here in helping to reduce the hypertension disparities were life course SES for all three groups and reports of discrimination for blacks, both low educated and highly educated. Okay, I'm going to try to summarize and put these together in the next couple of slides is again, what do I see here with midlife health concerns among these four groups? There's clear concern for low educated white Americans. Okay, in that sense, all of the scientific and policy attention that I pointed to earlier, I echo this. There are highest risks of drug use. I didn't show you here, but binge drinking, low educated whites and highly educated whites, and mortality due to the accidents and poisoning, suicide, and alcohol-related causes. These are all reflected in what we've seen in recent literature by Case Deaton and others, and by the results here. At the same time, low educated whites also share the highest risks of poor health in several domains with low educated Black Americans. Cigarette smoking, poor mental health, poor self-related health, obesity and related conditions, and poor immune functioning. So, lots of poor health among low educated whites, but it's not just low educated whites. A few things they really stand out on, but mostly shared in poor health with low educated Black Americans as well. But low educated Black adults also have higher risks than low educated white adults for a lot of outcomes as well. All-cause mortality, encompassing kind of, are you here or not? Okay, and not just what did you die from, but overall, kind of when we think holistically about mortality, there's no question we see higher rates, no matter with the increases for whites, higher rates among low educated Blacks compared to whites, and for a number of causes, including cardiometabolic causes, cancer, and then infant mortality as well, and hypertension. And the reasons, basically we could dig into a lot of these specific variables, but lower SES across the life course for Black, low educated Blacks compared to low educated whites, and the stress process, including reports of discrimination. So both of these important explanations figuring in when comparing low educated groups to one another. Finally, I think these results also help to show that there's been a number of studies over the years, and just echoing those here, that highly educated Black adults face higher risk than highly educated whites, and sometimes even higher risk than low educated whites for a lot of health outcomes, including all-cause mortality, especially when we compare high educated to high educated, range of causes, and then a range of health outcomes, including infant mortality, mental health, self-rated health, obesity, diabetes, hypertension, physical functioning, and immune functioning. So no, it's not the drug use or the alcohol use or the despair-related causes, but it's almost everything else. And again, if we look at the kind of global indicators of all-cause mortality and self-rated health, it's clear that that there's race disparities in health, both among those who are highly educated and among those who are low educated. And again, some of the same factors. It's life course socioeconomic disadvantages and life course stressors, some of which are largely unique to Black Americans that are playing out here. Okay, so is it socioeconomic disadvantage? Is it racism, or both that's kind of influencing our population health among young adults in the United States? Evidence points to both. Policy agendas that focus on only one or the other, on low SES among whites, or even low SES, and not focused on racism, is not going to be fully effective. Clearly, also, as well, low-educated white Americans are not America's most disadvantaged group with regard to health by any stretch of the imagination. For certain health outcomes, yes. For certain health behaviors, yes. But not for most. Okay, among the many limitations here, and this is where I'm going to start to urge way smarter people than me to focus on these issues. I'm looking here within groups by educational attainment stratification. Some people refer to it as composition, is not taken into account. In ad health data, for example, if you look at those with a college degree or higher, whites 44%, blacks 33%. So the processes of who even gets there, of course, are stratified as well. There's many other population subgroups to consider in work like this. Gendered processes of health that I didn't focus on here to focus strictly on race and SES. And then, contextual explanations, the neighborhoods people are living in, the counties, the states, and so forth. We need students and postdocs with much better analytic training and skills and more time than someone like myself to focus on the kind of fuller explanations of why these disparities exist. And these are pretty rudimentary analyses as well, that they don't, I use some data across the ways of ed health, but they don't fully, I don't use longitudinal modeling here. These are pretty simple models looking at kind of health outcomes at wave 5. So many limitations, much need for further work in this area. That's the sales pitch. I'm gonna now kind of move into this Lagniappe of ed health. I hope Todd Hamilton is on the Zoom here, and he grew up in New Orleans. He'll understand this a little bit something extra here to add to the talk. And so I'm going to talk a little bit about the ad health cohort context and this wave 5 data that are now available. Some of you may be using already, and I hope to convince some others of you to get a hold of the data and to use them. And then a sneak peek into wave 6, which is where I'm spending most of my time these days on getting wave 6 project up and going. So this is a pretty heavy 2 slides, but the ad health all cohorts are interesting and have amazing experiences that they work through. But the ad health cohort here, born around 1980, again, they were in middle school and high school in the mid 1990s, have lived through, I think, an amazing series of experiences. I won't go through all these here, but including, even rapidly increasing income and wealth inequality, wars, recessions, elections of President Obama and Trump, gay marriage being legalized, George Floyd and Breonna Taylor being killed, COVID now, 2020. And, these are still relatively young people. So the experiences that this cohort has been living through since they've been born have been, simply amazing to think about. And also in terms of health as well. The obesity epidemic really kind of took off in US data in the 1970s, where rates of obesity were something, I don't know, along the lines of 12 or 15% or something like that when these folks were born among adults. And in wave 5 data, it's now 42%. We've had some major improvements in control of hypertension and cholesterol, detection and treatment of cancer, in decreases in cigarette smoking. So a lot of great things happening in terms of health as well. But some others, the HIV/AIDS epidemic completely unfolding in the course of the ad health cohort's lifetime. Oxy being approved in 1996, and the whole opioid epidemic unfolding. And then, of course, COVID unfolding as well, just most recently. So as I think about this cohort, and again, I think about all cohorts in different ways, this is really a series of social, economic, cultural, and health experiences that make the analysis of this cohort particularly interesting. For those of you less familiar with ad health, Kathy Harris has shown this. She's so tired of this slide that now she's passed this on to me. That it's time to, this is the data collection for over the years that the main survey and contextual data collection in the blue in the middle started in the mid 1990s with a little over 20,000 adolescents, and the parents were surveyed at the time. And now we followed this same cohort of individuals through wave 5 that I talked about today, with over 12,000 completed interviews and a lot of biological data collection in the right on the green. So we've got GWAS data collected and available for most of the ad health cohorts. We've got data on cardiovascular markers, medications, immune functioning, and kidney functioning and so forth. And then we will, in the next couple of years, we'll be releasing data on gene expression data, epigenetic data, microbiome data, and more. So there's a lot of biological data coming. And then, of course, the survey and contextual data we're always adding to as well. So this takes us through wave 5. I was fortunate to be a part of this wave 5 data collection. I moved to UNC in 2015. So Kathy had just gotten the grant for wave 5 of ad health, but I was able to be there at the table for everything that unfolded in wave 5, and to play a part in this data collection. And learned a lot of lessons. What the wave 5 data collection was 2 pieces. There was a web mail portion of the survey with about 11,000 responses. And then a small in-person sample as well. Ad health survey data had always been collected in person. That was too expensive to do in wave 5. So let's go to the web. Let's try to collect data on the web. And so most of the data you can see, with 11,000 or so of the cases, were web-based survey data. And then, okay, can you answer these questions on the web? And then, okay, now can we come visit you to collect your health data in your home? So the in-home health and biomarker data collection was kind of like this second stage, if you will. There was the survey first, and then the health data collection, resulting in only about a half a sample. Ended up, we were successfully collecting the biomarker data. Most of this data has been released recently. It's available. Click on this. Ad health data are a little bit hard to get a hold of. There's a restricted contract. If you want the data, it takes some time, and our folks check to make sure that you got a secure place to analyze the data and so forth. But our staff are there to help, and the data are here for the scientific community. They're available. The survey data, the contextual data, the biological data. Okay, a few methods takeaways from wave 5 that I think it'd be interesting to talk to folks at Fragile Families to see what they've learned. But one of the things that we learned is that the web survey was a huge success, and collecting data on the web is cheap. So, again, these folks were in their late 30s. We, of all the people we sent, here's a link, please answer this, lots of reminders. We got over half of our respondents to take the survey on the web, and this saved tons of money. And we weren't sure that they would take a survey for close to an hour, and they did. We experimented with 20-minute surveys with two modules that were shorter, and people just plowed through. They went and took we got very few wanting paper, and the people who did answer the survey on paper, the data quality was much worse than those on the web. And so we're phasing the paper out completely for wave 6. We don't need to do that anymore among this group. But second, the people who answered the web are not random. So we needed to have a strategic non-response follow-up. Who didn't answer? Okay, so we got lots of highly educated people, especially answering the web survey. Let's go find low educated people, racial and ethnic minorities, and in the non-response follow-up. So it was really strategic use of resources to find the hard to reach populations and concentrate resources in person there. We did learn that the survey mode matters for some items, web versus in person. Remember, we had 2 subsamples here, so we can compare responses. The responses are not always the same. Kathy and others have some papers coming out on how the different modes matter for some survey responses that I think is really quite interesting. We learned that in-person sample too is valuable for some kinds of data, and we get higher consent rates for health visits as well. So when you ask people on the web to take the survey, then, oh, can we come visit you for a health exam? No, had enough of you. But if there's an interviewer in the house, say, take the survey. Now, can we send another person to come do a health exam? Over 90% of people said yes. So in-person surveys are more expensive, a lot more, but you're also more likely to get higher consent for a follow-up health exam. So there's trade-offs there. We know we need more attention in Wave 6 to retaining racial and ethnic minority participants. I'll show you a few ideas in a minute. People this age need great scheduling flexibility. FedEx doesn't deliver on on Sundays. So our blood's out there, and so he said, oh, okay, we can't come get your blood on. We can't do health exams on Saturdays. Well, a lot of people are home and they want it. So we're working really hard to try to figure out how to create greater scheduling flexibility for people. And then, people this age need constant context, decent incentives, and deadlines matter. Okay, please answer this. Last date is October 31st. And then they all start answering. Okay, so that takes us to Wave 6. My team and I were very fortunate to recently get funded for Wave 6. This is a kind of a major kind of career accomplishment. I'm super proud of all of us for getting this study funded. Basic schedule is we're working on a lot of prep work right now, development of instruments, IRB stuff, buying equipment, testing stuff, hiring and training people, and so forth. We'll test a field test in 2022, collect most of the data, and then get data disseminated in 2025. The overall goal here is we're collecting and disseminating data. We're not analyzing it ourselves. We will, but there's no time in there for us. It's all about, this is data to improve science. It's for you, it's for me, it's for all of us. There is no advantage here other than kind of we help design the instruments and so forth, but we won't have a proprietary period for the data. This is data for the scientific community. We want to better understand life course determinants and trajectories of health. That's what we're about. And the primary funder, and this is important, is NIA, National Institute on Aging. These folks are not adolescents anymore. Many people think of ad health and they're kids and they're in school. They're not. These are people who can be in their 40s, and they're not a healthy group as well. And so the challenge here is to maintain longitudinal integrity, but also while making significant innovations. And if I put one stamp of mine on the Wave 6 data collection, it's on disparities, is what we wrote into the proposal, not only in survey design, but also in what kinds of contextual data we're going to collect and append as well. But again, thinking about people in their 40s, issues of work-life balance, caregiving, being pulled and tugged in every direction, and the stressful lives that people are living in the COVID context, but even outside of the COVID context is really important. And then we're going to continue the work to collect really good health data as best as possible. We're also seeing we're up over close to 600 deaths in ad health already, and higher than I projected, higher numbers than I projected based on what we expected. So here's what we're going to do in a nutshell, and I'll wind up in just a minute. We're going to re-interview folks. We're going to revisit them to collect the home exams. We're going to follow to see who's alive and not. We're going to ask them if we can collect their birth records. The idea here is, as much as possible, we're trying to create a life course study of health and socioeconomic status and stress. Building these contextual data files, conduct some key assays of the blood we collect, but also we're archiving. We're archiving blood and microbiome and waiting for good ideas from people like you to propose to us, what do we need to assay, what's the scientific community need, and then we'll conduct further assays. I have more than this, but that's, I think, enough to give you a flavor of what we're doing. I'll stop for now, and then we'll turn it over to questions. Thank you for your attention. It's a lot, and I just encourage you to explore and hopefully use that health data.